Good afternoon, everybody. This is our next in our series of session 4 on hip and groin injuries, and we have a great lineup of international speakers joining us today. And our first speaker is a good friend of mine, Srino Bharam. He's a internationally recognized orthopedic specialist. He's been an active member of the International Society of Hip Arthroscopy, which is the main international society of hip preservation surgery since really its inception way back in 2010. And he is well represented in the literature across the world and has many authored peer-reviewed journals on hip preservation. And Srino is going to start the talk today by presenting first with us. So Srino, you're very welcome. Thank you for taking the time to join us. And if you'd like to share your screen, and we'll move ahead.
Thank you, Patrick. Thank you for the invitation, my friend. It's great to see you. Okay, let's see here.
And just like Ad, we're waiting. Just if anybody's any comments or questions throughout the presentations, please use the chat function, and I will try to either answer those live after the presentation or online ourselves. And so just please feel free to ask any questions or make any comments throughout the process.
Well, good afternoon, everybody. It's morning for us here in New York, but I'm happy to be here, and that's my disclosures. And I'm going to share this slide here because this was a meeting that we had in New York at the New York Academy of Medicine. These are hip preservation specialists who, the title of this was 2 decades of hip preservation. So, and this, I'll show you my tie to UPMC. We have next to me Dr. Mark Philippon, who brought us to UPMC in Pittsburgh back in 2001. And next to me was Hal Martin, who did that the 2nd year, and Dr. Brian Kelly the 3rd year. And then with him now, next to Dr. Kelly, we have Dr. Joel Mata, who Dr. Philippon brought as an open hip surgeon and great internationally known surgeon to Vail. Dr. Bully and Dr. Ranawat is part of Dr. Kelly's team at HSS. Dr. Travis Matheny, who's not only at Boston Children's, but he works with me for the past 12 years doing periacetabular osteotomy procedures with his mentor, Dr. Millis. Dr. Perotti was my chair, and that handsome man to the left is, as you know, Mr. Carton. So our relationship with Patrick, we started back in 2012. I'm just laughing because these are my kids back when they were toddlers, and back then we didn't have Zoom, so I actually had to go to give the presentation, which was a great honor, and it was just a great trip for my family. But reflecting back on it, not much has changed in what we've done and how we analyze myself and Patrick on dealing with hip preservation, although we've learned a lot from our patients and from our colleagues. Well, this started for me back in 2002, as I mentioned, when I started my practice, and FAI was not even on our radar. And it transitioned to understanding about how we can help these patients, but looking at in the lens of different stakeholders, where what I mean by that is the institution, the providers, industry, government regulations, right? And now we get into FAI and how that's transitioned, but also how it affects now this circle of stakeholders, right? Because now it becomes a little bit more complicated, indications, industry, cost containment, getting it authorized by insurance, and our relationship with industry. So I think we're coming to a point now where some of the institutions are starting to present their 10-year outcome. This is one of the society meetings that we did on our case study that we looked at when we instituted our rehabilitation protocol. So we looked at them prospectively. And these are our outcomes, which are actually good outcomes that we see on a 32 patient cohort. And it's similar to the systematic review that was published in 2023, that we had PAS of 72%, and the systematic outcome showed 75% of 10-year minimum outcome. And they had a reoperation rate reported between 4 to 24%. And we had a similar 90% survivorship for all outcomes, but they broke it down to tonus less than grade 1. And this is another study that Brian Kelly just kind of put out last month. Was an interesting study just looking at radiographic findings 12 years out. They just looked at the AP pelvis, but if they looked at 25%, they actually reported improvement of the tonus grade. And in comparison to the contralateral side as well, they saw some progression in certain cases. And if we look at what Chad Mathers showed, if we look at the effect and comparing what the benefit is, cost effectiveness of in comparison to conservative treatment, hip arthroscopy actually fared out very well. So if you look at CEA, quality of life years improved 2 years. And if you look at the 10-year society savings, you see that $65,000 for 10 years in comparison to conservative treatment per patient. Well, where's the value creation to this? To our athletes, as an alternative to total hip replacement, minimally invasive procedure, it improves function and return to activity. But it's important to have, and what I've learned over the years, to have a multidisciplinary approach to this. So as you can see, these are all the providers that in my world that I'm in constant contact with. And we see in the past decade that hip arthroscopy, we just look at the market in the US, has significantly grown, but this is also globally too as well. Well, we've also transitioned on how we manage the labrum. So when we first started in 2002, we weren't doing labral repairs, we were doing selective labral debridements. And Keelan actually was a big part of that because he rehabbed a lot of our patients with that very successfully. But as we improved our techniques, we've went on to doing labral repair and then now doing labral reconstruction in certain indicated cases. Well, as far as decision-making is concerned, when we partner with our open hip surgeons, we then look at from a different lens on how we can best help these patients based on mostly on correcting deformity. And so I've learned that it's important to have an efficient process when we're evaluating patients, but also be very dedicated into learning about their symptoms. Diagnostic imaging is a big part of how we work these patients up, and the management of mostly trying first conservative treatment and then the role of surgery or intervention. And then again, this is constantly patients coming in for their other hips or new symptoms. I've just got 2 calls this week on patients that I've treated back on 2012 and 2013. Well, this is probably the most efficient place that I visited. Dr. Thomas Bird, well known as almost the godfather of hip arthroscopy in our world. And he has a very efficient process where he has physical therapy in-house. He's got ancillary providers to do injections, and also he has a surgical center and imaging all in the same building. We just published this about a year ago just to show the different types of deformities that can occur if we're now breaking down to FAI on the socket side and the femoral side, and what some of the deformities we see on the acetabular side. This is just a variation of pincer deformities that you can see from focal to global impingement. And also sometimes impingement can occur on the socket from just labral ossification. In this case, this patient needed a labral reconstruction. And then how we manage patients with borderline to significant hip dysplasia. This was an outcome paper that we published in the AJSM on borderline hip dysplasia with a matched cohort, which even though they had lower preoperative scores, their outcome scores after 2 years were similar to our cohort of just FAI. But many other articles have also been published on borderline hip dysplasia as well. And now we're looking at the midterm to long-term outcome that's being published. Other signs that we think about are acetabular retroversion too as well. You can have subspinous impingement. This was a soccer player that had significant impingement noted from just a socket injury when he was an adolescent. On the femoral side, we see deformities noted as well. The classic are anterior hip impingement, lateral extension of the cam, which are a little harder to treat and manage, as you can see in this goaltender here from hockey. And then we wonder of the role of the epiphysis in causing these deformities, particularly when they engage in adolescent sports at the age of skeletal maturity. Now, this is a case actually that didn't really fall into the FAI. This patient actually had a basketball injury and was treated conservatively, but the physical therapist was pretty acute of the symptoms and realized this patient's pretty unstable. So we look closely at the imaging. You see this patient actually had a significant osteochondral defect that we couldn't just treat arthroscopically. And Travis Matheny, who I mentioned before, helped us with the surgical hip dislocation and to put an osteochondral graft, and she's 2 years out now doing pretty well. And another type of impingement that we see, and see this in the advanced population, greater trochanteric impingement. and ischiofemoral impingement, less likely that you see this in the athletic population. And then if we look at what are other type of musculotendinous injuries that occur in athletes, the ones that we see a lot are groin injuries. I've done a fair amount of work in this and also collaborated with Ernest Childers too, as you may know from the UK. We see that how we demonstrated how breakdown on groin injuries can be repetitive, also traumatic related. It's important to have a detailed exam to really differentiate between hip and groin pain and the pathologies too. It's very important to have a detailed history, examination, and imaging. And this is to show that sometimes if you just take care of the FAI, the groin pain can improve due to secondary induced from FAI. And this is just a systematic way of looking at, this is an arthroscopic technique that we've done for endoscopic adductor pathology. But as we learn more and more, that was a thing I published 10 years ago, we have a better understanding how to manage these patients and narrow down our indications for surgery. This is the outcomes of patients with groin injuries, having adductor avulsions and doing a surgical repair. And it's just so the return to sports and 2-year outcome. And then also very uncommon for female athletes. These are more predominantly male, but although we had this case report on a female with an adductor avulsion injury. The other types of injuries are less common that we see for gluteus medius, but it's important to understand the relationships of these because as these athletes get older, particularly females, lateral hip pain become much more prevalent. And how do we manage also other things of snapping IT band, as you can see in this patient here. And then we actually needing to do an iliotibial band release on this patient. But more commonly than not, they do respond to conservative management. Now, this is one of the first case reports that I did with Mark Philippon on addressing the lateral compartment endoscopically as well. A lot of my colleagues have taken this to a different level of how we manage gluteus medius tears, both endoscopically and also surgically too as well. This is something of a very large avulsion tear that you could do this endoscopically or open. And this is just utilizing anchor placements. But we've also showed the technique of how you can do this open in cases that require augmentation. Lastly, it's just my indications of how we implement biologics in this. This is using a needle scope camera called a nanoscope. And we actually started looking at data of 2-year outcome on patients who are not candidates for hip arthroscopy, but they may benefit from a biologic procedure. And now the outcome scores, this is just showing the nanoscope view that we use with a needle scope camera. The outcome scores are low, but we did improve them, but if in comparison to how the outcomes are on hip arthroscopy, they're inferior to them. Lastly, the thing that we're looking at now are the molecular analysis of FAI, and we've published on gene expression molecular, looking at not only the histological but inflammatory markers. And what we found was that CAM lesions actually have low growth activity, cellular proliferation for low apoptosis, and patients who are over the age of 40 have increased loss of potential for tissue regeneration and increased inflammation. In summary, I think it's important to have a multidisciplinary approach to hip disorders. We're still out on a lot of work needs to be done on how we can use and implement any role for biologics. And lastly, about can we start to look at AI for patient care algorithms? I just want to put a plug in for ISHA. I know there's a lot of physiotherapists on this webinar and encourage you to, there's actually a separate program for physiotherapists for our upcoming meeting in Washington, D.C. Thank you.
Thank you, Srino. Srino, we've got just a couple of minutes just for a couple of quick questions, and then we'll move on to Keelan's presentation. So, over the last 20 years, I mean, what are the main advances that you feel have contributed to a good patient success with hip arthroscopy and hip preservation techniques, mainly with hip arthroscopy, the arthroscopic way of trying to preserve the hip? So, I mean, what are the major advances you've seen over that 20 years that you feel have really contributed to advancement of postoperative success?
I mean, what I have to first say is the indications. I can't stress that more. I think that and if you look at some of the data, it's interesting. And I'm going to bring this up in one of the journals that we're going to review. I think that understanding indications over time, we've kind of narrowed them down, right? And it's still based on what we see with cartilage damage, is probably the biggest number one culprit. But understanding about the hip pathology and what their symptoms are. So for me, diagnostics, improvement of our imaging and our interpretation, I think, is probably the most important thing contributed to this. But more specifically, what you mentioned about from a surgical point of view, I think we're much more better refined now about labral management. We do have some options now that we mentioned before about augmentation or reconstruction, although that's still a very small percentage of how we manage the labrum, and also understanding best how we address FAI. We're starting to go through the pendulum a little bit of being less aggressive of resection, particularly of cam resections. Do we need to do as much to make it a perfect down to improving the alpha angle, or is it really more important to preserve the stability of that joint? The other thing that we're also still not having a clear understanding about is hip instability. We have a better understanding about when we can indicate a PAO and get them involved with borderline hip dysplasia. But I think the arthroscopic techniques of improving capsule management has also improved as well.
And I mean, the majority of the attendees today are from a physiotherapy or physical therapist background, and so with physiotherapy or physical therapy, you're faced with meeting athletes or patients without having the luxury of having the investigations that we have in our hospitals. And so we can have the X-rays and the scans and we can see everything. So when it comes to actually assessing patients, I mean, are there any tips that you can give from your perspective of what is an important patient finding that may suggest that the patient may benefit from further investigation as opposed to going directly with ongoing physiotherapy? I mean, are there any sort of red flags with respect to instability or dysplasia from a clinical perspective that you can help from assessing patients in this outpatient setting?
Yeah, no, that's a great question. I think that particularly for our providers who just dealing with physiotherapy, I think that a detailed examination is really important. And I find that physios who understand about their exam really know that, okay, this is something that's more beyond that, needs further evaluation with a full clinical assessment that involves imaging and a workup. And also number two is about their timing of their symptoms, right? So the advantage of also is if they're acute symptoms, particularly if they're an in-season athlete, I think the first line of physiotherapy and rehabilitation would play a significant role, because if they get better, then it doesn't matter what the imaging shows, right? This is where I always say, treat the patient, not the imaging. But however, though, for the best clinical pathway, Patrick, I think that the earlier the assessment, the better. The complete assessment, the better. It's better for the patients, better for the physiotherapist, it's for every stakeholder involved.
Okay, so thanks, Srino. We're going to come back to those topics, and we'll include Keelan in the discussion after the presentation is over. So I'll come back to you in about 15-20 minutes, and then so stay with us, Srino. Okay, and thanks a million for your presentation. So we're going to move on to Keelan and Enseki. Keelan is a gentleman who I met a few years ago at one of the hip preservation meetings. He works in Pittsburgh, and he's the director in Pittsburgh of the Clinical Practice Innovation and Physical Therapy Residency Programs at the UPMC Center of Sports Medicine. He also teaches an adjunct professor at the University of Pittsburgh, and he has a lot of research interests in the hip pathology treatments in active populations, and he plays a key role in professional organizations serving on committees such as the APTA, Academy of Orthopaedic Physical Therapy, and the American Academy of Sports Physical Therapy, among others. So Keelan is going to spend the next 12 minutes giving his wonderful insight into really managing patients with hip pathology from a non-operative perspective. So you're very welcome, Keelan. Thank you very much.
Thank you. And can everyone see my screen? I hope so.
I can, yeah.
Well, thanks for having me. This is great. Colleagues primarily on this call. I know there's some people from outside the organization, but as Dr. Carlton mentioned, I work for UPMC, and I have an interesting, and Srino alluded to this, pathway into how I ended up seeing a lot of these patients, both non-operatively and post-operatively. I started with UPMC in 2001, and as timing would have it, I was fortunate to come to UPMC around the time Dr. Philippon arrived, and along with him came my mentor in a lot of the hip world, Pete Dreyevich, who's now with the NFL, National Football League for American football. And I had a chance to meet Dr. Bharam and Dr. Martin and Dr. Kelly during that time, and have remained in contact ever since. It's actually a pretty small world with the hip rehab and just in general, these patients. So I was going to present on conservative treatment of non-arthritic hip joint pain in athletes. And a lot of this conversation will be centered around our fairly, it was last July, recently published clinical practice guidelines. These are available free. I have a QR code there. They're online as well, through the Journal of Orthopedic and Sports Physical Therapy. Now, for these guidelines, I'll focus primarily on intervention. And just to put it so everyone's on the same page, so to speak, we made recommendations based on the evidence available at that time. The A through F, right? So A is the strongest recommendation, F being the weakest. That being said, F isn't necessarily a bad recommendation. It's not a report card, more or less. It's a snapshot, though, of how robust or the lack of evidence we have for making these recommendations for intervention. And you may look at this and say, well, that's not the greatest. But if you looked in 2014, when we published the first version of this, it was all Fs. It was all expert opinion. So we do have studies now to back up what we are doing in both the assessment and, in this case, what we'll discuss, the intervention, non-surgical intervention. And kind of looking at this in a little more detail for intervention. So, we have a B recommendation. Our strongest recommendation we can make is a B level, and that's for multimodal treatment. By that we mean, or what we're representing is that the fact that many of these studies, primarily most of the studies that look at intervention for non-arthritic hip pain, a lot of this is around femoroacetabular impingement syndrome, other non-arthritic conditions to a lesser degree, has primarily been done on these with protocols that have had a mixture of different interventions. Now, all those interventions are now on your right. And so when you start to really try to isolate the effect of a single intervention or specific intervention, the literature is not as robust and the evidence is not as strong. And I think that's just kind of the reality of where we're at. And you can see, and we'll discuss a number of these separate interventions. But the B-level recommendation, again, recognizes the fact that most intervention studies for non-arthritic hip pain, at least physiotherapy studies, really do look at a mixed approach. And we are in the process of trying to determine which components of that mixed approach, the multimodal approach, may give us the most efficient or the best results, for this patient population. So, when we look at, and we gave the C-level recommendation for therapeutic exercise, it's also important to note, if you would go through the practice guidelines, that most of the therapeutic exercise research for non-arthritic hip pain in the non-surgical population is centered around strengthening interventions. But it's important to also note, what we can often do is take these practice guidelines and then go further into the literature to get some more specificity in what we should be doing. We know we should have a selective strengthening approach. We'll talk about that. This seems to be, common sense, but sometimes it is underappreciated. Appropriate dosing principles. So there's a difference between recruiting the muscle that we're trying to target and then dosing appropriately in our athletes to actually create a strength gain or a local muscle endurance gain. That's very important. I think under recognized or underappreciated, and then progress towards functional requirements. There's numerous studies out there. Most are EMG based that look at selective recruitment of muscles. We're often targeting the gluteus medius, gluteus minimus. They are recognized in the non-arthritic hip pain population as being weak, both from involved to non-involved side and amongst controlled peers, if you will, in athletes. But it's also important to note, most of these studies, a lot of them are done in the healthy population. So this is a great study. I like it because it's the Collins study. Excuse me, I'm ahead of myself. It not only uses EMG findings, it also uses force plate data as well. And what they did, and I do like the fact that they did this, they took these exercises. They also took exercise that we commonly do in rehab and added weight to them. So this is our athletic population. But we should realize is the assigned tiers to these exercises. And kind of the take-home message here is that these are all great, but they're great when timed appropriately. So for our individual who's presenting more acutely, maybe has poor neuromuscular control, for me to take that single leg RDL, as you can see on your right, or a side plank, and they are too irritable or don't have appropriate neuromuscular control to even stand on one leg, in the case of the RDL, Romanian deadlift, single leg Romanian deadlift, the exercise is not useful, not appropriate. So we may start at a tier 1 or tier 2 exercise near the bottom, despite the fact they don't recruit quite as specifically, and then move our way up. So using the exercises in and of themselves as milestones and criteria to move up to the next exercise. A lot of what I'll stress today is that approach, is meeting clinical milestones to appropriately progress your rehabilitation while trying to minimize joint irritability or symptom irritability. But also, much as is the case with the shoulder, we have to think centrally. So proximal stability being important. And in this case, not only are we dosing for 1 repetition max, what we may capture in our strength testing, there's an endurance component to this. So if you think of the shoulder, proximal stability, scapulothoracic stability, we're looking at lumbopelvic stability here. And as you can see in the individual here, who has quite an extensive hip history, we have her focusing on pelvis on femur movement. I'll talk more about that later. You can see I move her from a 4-point support to 3-point in a plank position using the Blaze Pods, which I have no affiliation with, or any neuroreactive type of activity to make it more challenging. And that's something we have to consider as well. It's very much the same mindset, if you will, that we take when we're rehabilitating individuals with shoulder injuries. We need a good platform and foundation to work upon, as we're also focusing on that peripheral strength. And the restoration of rotational stability we find particularly important in our athletes. Of course, regardless of the underlying condition, we focus on FAIS in this talk, but it could also be various conditions with leading up to the clinical entity of instability. If the labrum is injured, we know that subtle rotational instability may be present. So you can see my wife, she obviously has allowed me to share this. She's a physiotherapist. For over a decade, has a known labral injury. In this case, we see her isolating external rotation, very controlled manner, partially loading as you move from left to right. Then we have our individual has anatomical FIS, but is a competitive kickboxer with micro instability. We are focusing that pelvis on femur rotation, adding in resistance. And then we have our hockey player who's was collegiate at the time, now working on explosive movement. But again, isolated to multiplanar, speed is controlled to ballistic, unloaded to loaded. So we have a clinical rationale for how we progress these individuals. And I think the biggest mistakes are not so much that you're using the wrong exercises, it's the wrong timing when we have these individuals that we just can't get them out of that stage of irritability. So maybe prematurely having them go through exercises, which you're just not prepared to do yet. And then we do have a recommendation for education and activity modification. It's a pretty broad category. In our athletes, often what this entails is initially pulling back from activities that are symptom provoking. And we can take our subpopulations into consideration here. So if the FAIS, I think this is fairly straightforward, those activities that are causing impingement, if they're sport specific or maybe part of their preparations, we may have to take them away from those activities. We know that's temporary. At some point, to say that we've successfully treated the patient, they have to be able to go back into performing those activities at a satisfactory level. For some of our instability patients, again, pretty broad category. I'll use micro instability as the example, where we may have to pull them away from those forced externally rotated and extended positions, what we commonly encourage in athletics, reintroduce those as they become less irritable and as they develop better physical performance and we address their deficits. So we gave this a C-level recommendation with the literature that's available which is primarily focused on the FAIS population. Motor control and movement quality. We have 2 recommendations here. I won't touch upon in too much detail the movement pattern training that comes out of the WashU group in St. Louis. A lot of that is centered around ADLs, identifying painful activities, educating the patient how to perform them in less painful manner, and then having them practice that, come back, and then moving up the scale. It hasn't been looked at in athletes. It's just, I think we're centering more around athletes today. I'll keep that under kind of this motor control movement quality recommendation. It has some extensive research, much more than just pure neuromuscular control. So it does have a stronger recommendation. But in our athletes, regardless of it being an F, we know this is important, because what we do know is that these individuals do move differently, and we'll briefly speak to that. If you want a clinician, what I think is a fairly straightforward clinician-friendly paper, we completed a Delphi study recently to get consensus on how do we functionally evaluate these individuals to then drive our rehabilitation. So using these functional performance measures. And we came to a consensus to try to give you low, medium, high intensity activities that are based on speed, planes of movement, and impact. Sport specific is kind of its own animal. I think we all understand what that means, and it's specific to that sport. And it gives you a rationale for where they are in their rehab, how acute they're presenting, how we assess their movement quality, and then match rehabilitation to address that. Now, what we should note, this doesn't, as Dr. Bharam had mentioned, the clinical exam is imperative here. This is only one part of it. So if they are moving, if they're showing movement deficits, this doesn't tell us whether it's strength, pure motor control, endurance, pain. We have to go back and we have to go through our thorough clinical examination to determine what is causing this movement deficit, how do we address it, then bring it back together and converge into improving the movement quality. Because what we do know is that these individuals, as I mentioned, do move differently. The literature shows they perform differently, particularly when you get them off 2 legs into 1 leg type of tests. Single leg squat, step down test, the STAR excursion balance test, very well known in the knee population, maybe somewhat in the hip as well. Well, there's evidence to show that these individuals do perform differently if they're symptomatic on one side versus the other, even if anatomically they have this kind of similar findings on the other side. If they're symptomatic, they perform differently, or they perform differently amongst their peers who do not have these anatomical predispositions. And some of these, what they do, these movement deficits also correlate with patient-reported outcomes, and in some cases, strength for the SEBT test. Additionally, very small study, so you take it for what it is in terms of the strength, but the group in Texas and some of our colleagues here at Duquesne University in Pittsburgh have shown if you can improve that deficit that is recognized on exam in the non-arthritic hip pain population in conservative care, improve their movement quality, they do show or do report less pain and less disability, if you will, or improved functional ability in ADLs and sports specific is related to patient-reported outcomes. This is a great study. It's, again, you take it for what it is in terms of the number of subjects and such, but it does give rationale for improving function and getting better outcomes, that are patient-reported. What I will note, though, is, again, we don't know exactly what made them move better. This is multimodal treatment, so your clinical examination, it's always going to come back to that. We need to get them moving better quality. How we get there, that is still up in the air. And then, there is always the manual therapy, right? Joint mobility, range of motion. Not a lot of research on that. What I will note, some of this is more anecdotally, is, of course, we have the indications, painful evidence of capsular restriction. Some of our FAIS patients, I think of our senior athletes, and senior not being old, just means senior in terms of the competitive level. Some of the FAIS patients may be moving towards a bit of an arthritic condition type of presentation. That population, I have definitely seen utility for manual therapy, and that I mean joint mobility, though other manual therapies can be used as well. The contraindications are obviously the unstable hip. We probably do not want to mobilize, even at times when it may feel a little better temporarily, that hip joint that we know is already unstable and has challenges. The F level basically means there's not a lot of research that isolates the use of manual therapy for this population. Okay. But what about stretching the unstable hip? So the conundrum here is that we get our dancers, our gymnasts. We know a lot of them are unstable, right? It's probably what got them there part of the way in terms of doing well half the time. And they always want to stretch. We see this post-operatively too. There's a little bit of a bargaining session often with these individuals. We have to reach some sort of compromise. So, if they're going to stretch and they're not going to listen to us telling them not to, right? What we'll often do is kind of make a deal, if you will. If they can develop the appropriate strength, motor control, and endurance to control that movement that they are now creating by stretching, that's kind of the deal we'll make with them, so to speak. I will try to stress a dynamic warm-up to decrease that feeling of stiffness as opposed to very long, prolonged stretching, particularly an extension where they're just hanging out where we already know they're unstable. It's no doubt this is a challenge, and it's probably patient-specific as to what compromise they're willing to make, but we do realize it is an issue. Finally, psychosocial factors. Now, there's emerging evidence to show both in non-operative and operative population that people particularly with FAIS, they do have at times psychological factors that could affect their outcome. Our colleagues, Kate Jorgensen lives in Pittsburgh, works for Harvard and MGH. She has shown that people with FAIS have a higher rate, if you will, of depression and anxiety, low self-efficacy, and kinesiophobia. Some of these people are afraid to move, and that's including our athletes. And again, that includes people also who are going into hip arthroscopy. So we make a C-level recommendation. I would say the take-home message is to screen for these. If you think psychosocial issues are there, don't ignore them. They could affect your ultimate outcome, and they are also potential issues, including in our athletes. Finally, a lot here, but each of these QR cards will take you to kind of the reality, right? We look at non-operative rehabilitation, where the evidence is what we have here, our clinical practice guidelines, and we know where that's rated. Post-operative rehabilitation, even less robust evidence. And as we move to return to sport and performance metrics, even less. So the take-home message is we still have a long way to go. I think we've come a long way. from 2014 when we did our first CPG. But there's no doubt we're not anywhere near the ceiling of knowledge we really will ultimately need to provide the best care for these individuals. And we do this as as Dr. Bharam mentioned, as kind of a team, right, with our physicians, our surgeons, and other specialists. And then finally, I think this is a good place to end. It's where Dr. Bharam ended. What do we do with that individual? How long do we keep them in rehab? There's definitely evidence to show if we keep them there too long, and I won't go over all the individual results of the study, after being symptomatic and with known anatomical predispositions, we're probably doing them a disservice on how they will do afterwards. And those known anatomical predispositions, physicians can speak to them, or surgeons probably a greater amount. But when we have those large alpha angles, a large, cam, very symptomatic, it's been there a long time, and a high-level athlete, they're probably more likely to have to go to surgery. What about individuals who have shown, in the dysplastic hip, and we know that they're very symptomatic, been dealing with this a long time? There's a window there where they could be out of that window for maybe they're a candidate for PAO. So we have to be realistic, work as a team, and know when it's time to move these people along. And there's evidence to show that as well.
That's great. Keelan, thank you very much. Great to see. I don't often get to see the sort of the focus and a lot of the meaning behind some of the conservative treatment measures that are being used to try and manage the patients with non-arthritic hip pain. And it's a. Do you find that in where you're working in UPMC that there is a very clear sort of vision from the physical therapists and the physiotherapists as to how this type of hip pain is treated, or is there a lot of variation even within the UPMC network and out in the community? How much is the message that some of the research that you're presenting there are getting through and across the board and being utilized?
Yeah, you always want to present the best picture, but I think in truth, there's definitely variability there. And I think what you'll see, and things, meetings like this will help and actually help to kind of even show this, is that we have our circle of people who are involved in hip preservation and see these individuals in higher volume, and some that may be geographical, some just where you're practicing. And then as you get kind of further away from the center of that circle, the people see these patients in high volume, work with our surgeons, and part of the team, maybe even work with athletes who have this, it becomes less consistent in practice, I think, and just less understanding. I think a lot of that is exposure, and thus the need for meetings like this to increase that exposure.
And I'm going to ask you the same question I asked Srino. Srino, about the main changes in surgical techniques that have maybe improved outcomes. What do you feel are the main changes in how we manage the athletes conservatively that have had the most impact, do you feel, on a successful outcome?
Yeah, and I can actually, from a different perspective, echo what Dr. Bharam said, in that selection. So we do have a better idea now, and if we have a patient that comes in who may or may, and particularly our athletes, who may or may not do well conservatively. So we always tell our patients that come in, especially our athletes, don't like to come in and be shown how either weak they are or the quality of movement they have may not be, even our higher level athletes. I'm glad to see that, because I can change those things, right? If I have the athlete that comes in who is, and I think of our very high level athletes, hockey's, I see a lot of martial artists, pristine, I can't find any movement impairment, I can't find a strength impairment, but very acute irritability. We know from our surgeons, if they saw them first, or our specialists, they have all the anatomical predispositions are in their very evident. We know that we're working with a much smaller clock with those individuals. I always think of putting these people on a clock. If I have a lot of things I can work on, that clock may be bigger, more time. If they come in and there's not much I can find, I think the reality, is Dr. Bharam had mentioned, is that we have to start thinking down the line, as a team, and how these people may be in surgery faster than they would be with us. And I think we're much better communicating with our surgical colleagues about that. And I think we have a much clearer picture of who may or may not do well in rehab. Now we know that the deficits that we hope are there, I guess, that we can change in rehabilitation.
And how long do you give to try and turn those deficits around? Is it, are you talking about weeks? Are you talking about months? Obviously, there's a difference between a professional athlete who needs to get back playing quickly, and maybe a non-professional athlete or an amateur athlete who maybe has more time to work on progressive rehabilitation. So I want just to give an idea of the sort of time you spend with an athlete who comes to you with a chronic hip and groin pain. Or hip pain specifically.
So If in a month I have no change, the chances are me making changes at 3 months, probably not. But if I can relieve their symptoms within that first month, start to see better movement quality, by the time we hit 3 months, we have definitely given them enough time to respond in terms of strength deficits. Neuromuscular control will probably be improved before that. So if we hit the 3 month mark and we can say we've seen acceptable improvement, that means acceptable to us and to the athlete, we feel pretty good about it. And again, there are other factors, obviously, in higher level athletes. But if we hit that point, and even if they made improvements, but they feel like they've hit a ceiling and they're not improving, I think then it's time to have a very sincere conversation of, if we aren't getting you there at this point, if we get 6 months down the line, I can't really confidently say you're going to be much better. And then we start looking at what have we lost that may be part of the surgical outcome, or are we affecting the ultimate surgical outcome if they end up going to surgery?
Okay, Keelan, I'm going to leave it there for a moment. We're just going to present the results of our paper, and then we're going to have a discussion with yourself and Srino just briefly at the end, and we can field any questions if they come through. So, David Phelan, our senior clinical researcher, is going to present just a summary on the paper that we had sent out for those who are interested in reading it. Okay, David, thank you.
So this paper was published in 2023 in the American Journal of Sports Medicine. It focused on the long-term outcomes of primary hip arthroscopy with labral repair for FAI. The main aim of this study really was to evaluate the long-term patient-reported outcomes of primary hip arthroscopy with labral repair for FAI. They also sought to the aim was to report patient-reported or metrics of clinically important improvement, including patient acceptable symptomatic state and minimal clinically important difference, and also to investigate the rates of reoperation and progression to total hip arthroplasty. This was a case series. The inclusion criteria was patients undergoing arthroscopic correction between 2010 and 2013 who were placed on an online hip arthroscopy database. These patients have all failed conservative management, and they have to have undergone primary hip arthroscopy with labral repair. The authors then excluded any patients who underwent labral debridement, any revision hip arthroscopies, patients who underwent common PAO, and who had no pre-op patient-reported outcome measures recorded. The methods of assessment then, this was a review of medical charts really for patient demographics, outer bridge classifications, and various intraoperative procedures and revision surgeries. They evaluated patient-reported outcome measures post-operatively, and these included the visual analog scale for pain, the hip outcome scores of activity daily living and sport-specific subscales, modified Harris hip score, non-arthritic hip score, the IOT-12, and then satisfaction with respect to improvement and with respect to surgery. And they also evaluated minimal clinically important difference in patient acceptable symptomatic states, the rates of achievement of these, and these thresholds were based on previously published values. The results, there was 45 patients considered, of which 40 were included after considering the inclusion and exclusion criteria. 8 were lost to follow-up, leaving a final cohort of 32 patients. The average age at the time of surgery was around 27.7 years of age, and there was a majority female cohort. The results from the PROMs, then there was 32 cases evaluated with respect to the patient-reported outcome measures, or 17 had patient-reported outcome measures available. Overall, there was a significant improvement in outcome measures from baseline to minimum 9 years post-operatively for the majority of the outcome measures, apart from the non-arthritic hip score and the Tenger activity scale. A large proportion of cases achieved minimal clinically important difference, about 70% across all different outcome measures, and then a lower proportion of cases achieved a patient acceptable symptomatic state ranging from around 30 to 50%. The mean patient satisfaction was 8.1, 67% reported at least a mild improvement, and 71% reported their hip being normal or near normal at the final follow-up. The results of the reoperation and conversion to total hip arthroplasty. So 4 patients converted to THA at the final follow-up, so a 12.5% conversion rate. 2 patients underwent PAO, and then 8 patients underwent a repeat hip arthroscopy. The limitations were acknowledged by authors, and these included response bias, so only patients not lost to follow-up or followed up or reported on. Not all patient acceptable symptomatic state and MCID values have been validated for long-term follow-up. So as I mentioned, these the thresholds were based on pre-published values, and there was a small sample size. In conclusion, the authors concluded that patients demonstrated significant post-operative improvements in the VAS, the Modified Harris Hip Score, IOT-12, and subscales of the hip outcome score at mean 9.4 years post-operatively, with an overall satisfactory rate of reoperation and conversion to total hip arthroplasty. The all-cause reoperation rate was 34.4%, and 12.5% of patients progressed to total hip arthroplasty. And the data then, as concluded by the authors, support an effective and durable outcomes of hip arthroscopy at long-term follow-up. So that's the overall the results that were reported in the paper. I'm just going to go through a critical appraisal summary, which our delegates have filled out, and this kind of gives an overview really of how people interpreted the paper. So overall, 20% of patients felt that there was a comprehensive overview given in the background. 6% felt this was sufficient, and almost all people filling out this survey felt that the rationale for the study was clearly stated, and 80% felt that the objectives were clearly stated. With respect to the methods, 80% of people filling out this form felt that the population was appropriate to answer the question. 60% felt that the inclusion-exclusion criteria were appropriate, and also that the methodology was sufficient to allow replication of the study. 60% felt the statistical methodology was appropriate, 20% were unsure. And with the results, actually nobody found that or reported that the findings were novel. So some of these maybe reported before in other studies. 40% felt that they were not novel, and 60% felt that the results published were novel. 40% felt that the results allowed for a clinical interpretation of importance, and 40% felt that this wasn't the case. And again, 80% of people filling out the form felt that the data was presented in a way that was easy to understand. With respect to the limitations, only 20% of people who filled out this form felt that the limitations have been sufficiently highlighted. 80% felt that the limitations confounded the actual robustness of the study. So I'll hand you back now to Mr. Carton and our two international experts who may be able to provide more insight into the interpretation of this paper.
Okay, regarding the paper, Srino and Keelan, did you get a chance to read through the paper? I'm not going to go into it in too much depth, but this is a classic, a surgical cohort study. There's no control group, and it's over 9 years, which is we're looking for long-term results from whether you treat somebody with a surgical intervention or any non-surgical intervention. It's important to know how that is going to actually affect regarding the success going forward, and not just within a year or two, but it's important to know how much is our intervention having success in the longer term. So especially from a surgical perspective, you want to make sure that the surgery you're doing is doing no harm, and that it continues to do good. So any comments on one of the things that maybe some of our readers who read the paper and viewers, we talk about outcome assessment a lot, and we talk about what's the right way to look at how a patient improves after an intervention. And so in surgery, we have very clearly defined ways of measuring things, and we can measure the improvement of the morphological alterations we do with the surgery. We can use X-rays to measure that. We can use range of movement assessments, both post-op and from a non-operative assessment as well. But we use these sort of patient-specific and joint-specific outcome scores that sometimes become a bit meaningless, and as time goes on, and a lot of readers don't really understand the importance or non-importance of these outcome scores. So in this paper, they've used the IHOT-12, they've used the hip outcome score, the non-athletic hip score. So they've used a lot of the scores that are used to look at improvement in hip function. I mean, what are your brief views on the best way to measure how a patient improves following a non-surgical or surgical intervention, and with respect to the hip joint? Srino, do you want to take that one first?
Yeah, sure. I know the two of the authors on there on that paper, and they're great surgeons. I'm a little surprised I'm not surprised because it's a long-term outcome, but the higher from a smaller cohort of the reoperation rate, that's a little high from some of the other longer outcome studies, but that's great that they published it. Part of it has to be about, where they were in their careers, and indications and things like that can also be a factor too. We just don't know. But however, though, I could just tell you personally, it's just very taxing, though. So to do a 9-year, 10-year, or anything long-term outcome, because now you're, in some ways it's good, in other ways it's challenging trying to reach the patients and things like that. To answer your questions about methods of outcomes, I think the outcome measurement tools that we have, when it's longer term outcomes, just the most important thing is just their satisfaction, number one. Two is about survivorship, right? I think those two benchmarks are critical and good comparisons when we start to look at some of these long-term outcome data, right? Because in the short term, it's easier for the patients to think about their surgery and things like that. A lot of times patients put it in the back burner. If you actually contacted personally some of your patients, or you've seen them now, what I'm doing now is actually seeing patients that we've seen taken care of a decade ago and stuff like that. So that's another opportunity to get to see those patients.
And Keelan, any advice on from what's your feeling on how best to measure a patient's improvement, even 5 years or 10 years following non-surgical interventions?
Yeah, and I know survivorship is, as you mentioned, on the surgical side, and I think Srino put it the way I would say it too. Again, the legacy measures and such probably don't mean as much at that point to me, as much as patient satisfaction. Athletics is tricky because if you get this far down the line, if you return to sport, how you're doing your sport is also confounded by, especially higher level athletes, the fact that 5 years down the line, a lot of us are not at the sporting level we were before. So I think that's not always captured, and it's not meant to be captured in this particular paper. But that is a conversation we often have. How much is more kind of attrition, and how much is more directed toward the intervention that they received.
Yeah, and I know in this paper, particularly, just before we move off the paper in a second, when I read that paper, I agree with you, Srino, the results are not great. And so there's a high revision rate, there's a high conversion total hip replacement rate. But the problem is that they don't have a clear cohort of FAI patients. They have 25% of the patients are dysplasia. They also, about 40% of the patients they performed an iliopsoas lengthening on, which is known to significantly increase your complication rate and your per outcome rate. Right. So they've mixed a lot of different cases. They had other intraoperative surgical ligament tears, debridements, and various things in 25% of or 10% of cases. So all of a sudden they're presenting a mix of patients, I think, because they don't have the numbers back in 2010, whatever it was, to satisfy a 9-year paper. So I think the paper was too early, and I think they needed to have a lot more numbers so they could focus their cohort on the FAI group in particular. And I think they may have had better results if they had done that. So I know you and I both published our 10-year paper, 10-year outcomes, and I would have been disappointed if it had been similar to unfortunately this paper's outcomes. But now, I want to talk a little bit about just going back to more assessment, because I'm aware that it's a surgical paper, and we've presented a lot of non-surgical papers the last few months, so that's the reason why we've just put a surgical paper on today. But we'll get back to non-surgical issues. So joint mobility. Okay, so one of the important things for me as a surgeon is assessing joint mobility preoperatively, and making a decision as to whether that joint mobility is something that is a morphological obstruction to movement versus a temporary restriction of movement. And so how do you assess for that clinically, Keelan? Is there any way, for the physiotherapists and physiotherapists who are out managing these patients in the community, how do they know whether this is a bony restriction to movement that is not going to improve with rehab, as opposed to a thickened labrum or a capsular restriction, or something that may benefit from joint mobility exercises? Any tips for the physiotherapists out there in that type of scenario?
Yeah, and this is kind of we call it, I guess, a soft skill, but important skill. Often, and when we are doing our range of motion assessment, we try to make it, we want to make it objective. So, you hit an end range of motion, and what is the cause? Is it pain with an empty end feel, as we would call it, where it's just patient, irritability? That doesn't really tell you much about the bony anatomy. And then where it's a little bit of a softer skill, is there some give where it's kind of a capsular type end feel, or is it a hard bony end feel? Maybe pain ensues afterwards. That in itself can help us determine what is the cause when we're hitting that end range. And that is a challenge sometimes, not always the easy, especially when you're trying to determine capsular versus bony. Then we'll also look at range of motion pattern deficits, arthritic hips, if we're trying to question that. Sometimes you'll start to see that characteristic kind of capsular pattern. That's, again, sometimes debated, not 100%, hit rate in terms of diagnosing OA, but that is one of our differentials at times. So I would say end feel, patient response, and then looking at particular patterns if they do exist. Versus maybe a muscular infill you'll find at times too. Someone's just tight from a muscular tendinous perspective. Okay,
and how long would when you start working on doing some of the measures to try and relieve that joint immobility? How long do you give it before you realize? This is not improving, or maybe would you expect to see improvement within a week? Does it take a lot longer than that? And just from a non-physical therapist perspective, when you're working with these guys, how quickly do you expect to see some response to the activity that you're giving them to do?
That's a good question, and there's a lot of criticism of manual therapy because we kind of give these mechanical reasons why we think it works, but the evidence actually shows that it may be much more complicated than that, and some of it may be more of a it addresses guarding or other issues that are not even truly structural. But if the cause is more pain related, or we'll just say guarding, muscular guarding or tone, that's a pretty quick response you'll see. I mean, if not in session, within, I'm just going to put an anecdote, a week or less. If it's capsular and we think we can truly change those capsular characteristics, there's a lot of challenges to that too, how much we can really change from a capsular restriction. But even then, if I'm not seeing a change of some sort within, for whatever cause, and if I don't even, sometimes know the fully understand the mechanism why this works, within a few weeks, I'm not going to just keep mobilizing that individual. I think we've exhausted we've kind of hit the ceiling on how effective that will be. So I think the bottom line is you'll usually know in a fairly short period of time whether manual therapy techniques are going to be useful for these individuals. Okay, and just at what point do you get further investigation, as an X-ray or MRI because sometimes if you're managing a patient and you don't have a clear diagnosis, is it how can you take the management of that patient? How do you know you're taking it the correct way? Whether it's a professional athlete or a non-professional athlete, get an investigation or gets some sort of level of diagnosis, so you can really make those treatment decisions more effectively. Yeah. So some of that is, irritability helps guide that, but and there are other circumstances, as you mentioned. I will, if I see their impairments are improving, they're functionally, and all the impairments that we discussed, yet their clinical presentation does not change, gets worse. That's obviously another thing. That drives that decision to refer quicker. It could be well before, it could be a month or less, but then I refer them. If I'm all of a sudden finding no reason that I should have them there that I can physically identify. Now, the other issue is if they're not improving, and probably not much more time than that in their physical impairments, and they're still acutely presenting, then whatever I'm doing is not working then either. So again, those are pretty quick referrals. The gray area is when they are improving at whether it's slow or we are seeing improvement in their physical impairments, and symptomatically they're improving some. That is the gray area there, because you have to determine whether you feel that's a satisfactory improvement. And sometimes your PROs can help you there if you want to go back to the past scores and MCIDs and such. And does the patient feel this rate of satisfaction? Are they satisfied with the rate of improvement as well? Those are the toughest cases. I would never keep anyone more than 6 weeks of formal rehabilitation if they couldn't tell me they were making significant improvement, if I didn't feel so either. And often much sooner. Okay, I'm going to come on to just injections in a second. There's just a question there. How do the findings from the paper of all-purpose reoperation of 34% and conversion at 12.5 compared to what consultants see in their practice over longer term? Well, I can tell you now, our 10-year results are 8.4% conversion to THR, so that's as opposed to 12.5, and our revision hip arthroscopy rate is 5.9%. So that's a total of 12% compared to their 34%. So about a third in our series compared to this series. I'm not too sure, Srino, if you have any numbers offhand, but what do you think your 10-year outcomes are regarding reoperation and conversion rate?
Yeah, we have our conversion rate on that paper we I just showed, and that was the 90% survivorship. And then as far as for obtaining PAS, we measured that. It was 72%. So that systematic review, on average of 12 papers, 5 of them only reported PAS, and that theirs were 75% collectively.
Yeah.
So, just
Okay.
around that area.
Another question, Keelan or Dr. Bharam, do you have any thoughts on realistic expectations for either conservative or operative management of the improved but not resolved patients? So somebody who has improved, obviously with non-surgical issues, non-surgical management, at that point, would you continue to offer a different type of conservative management, or would you consider surgical management? I mean, I think what's your thoughts on realistic expectations there? Srino, do you want to answer that first?
Well, yeah, so I think, I mean, that happens quite often, right? And this is where the follow-up of any type of plan that we give these patients is critical with them. We want to share that with them. Whatever conservative management that we do, I first mentioned that we want to see improvement first, right? Having said that, though, it's also a little bit more so, a little more detail about their goals and what their expectations are and who they are, right? If we're talking about athletes, then a lot of the times it just falls into an in-season athlete. Can we get them through their sport? Can they do with some modification, right? And then a reassessment when they're off season. So I think from a clinical point of view, I think on a 30,000 foot view, bird's eye view, it's really matching their expectation of where they want to be, in spite of just treating any major deformities around the hip.
Okay, and Keelan?
I would echo what Dr. Bharam said, and then really what we'll, if it comes down to realistic, a lot of times these individuals are trying to decide, should I get surgery, should I not, stay with the conservative track, and as Dr. Bharam said, are they satisfied where they at? If they stayed there, do they feel like is it worth it to them, to go through surgery to potentially reach that ceiling that may be higher with surgery? And then what I'll do from our perspective is explain what the rehabilitation process involves, the time that it involves, and then what we try to do is fully inform them of the process and to the best of our ability, the potential outcomes. And so for a recreational athlete, something that they may just say, I'm okay, and then our plan will be, if you get considerably worse symptomatically, here's the plan B. Maybe now it is time to, and try to set some thresholds there. That's a sliding scale, but we fully disclose what rehabilitation involves either way, and then really tell them what to monitor for, and then set it in line with their goals. So really echoing what Dr. Bharam had mentioned, with a lot of patient education and communication with our surgeons and other specialists.
Okay. We're approaching the end point here, so just want a quick sort of response to this one, guys. On your thoughts of the use of cortisone injections into the hip joint in patients who don't have arthritis. Okay, so young patients with non-arthritic hips. And is it widespread in your practice that you would use cortisone to try and help alleviate symptoms and get people playing through the year, or is it something that you try and avoid? Anybody, Keelan, if you want to answer that one from a conservative management point of view, first of all.
I don't see it a lot, at least with the physicians I work with. And not that I don't see it, but I don't see it. And I feel like I'm seeing it less. I don't know if that's just bias based on who I work with, and maybe just by chance. I don't have large numbers to tell you that one way or the other. As a trend, I believe I'm seeing it less in our practice and what I see.
Okay. And Srino, any concerns about the chondrotoxic effects of cortisone, or it's the other chemicals are involved in the injections, or are you not too concerned about it?
Yeah, no, we're actually with the lab that have been working on molecular analysis, we actually have a study approved to look at chondrotoxic effects of steroid from the tissue donation program. So we're actually studying that this summer. It's hard to kind of study that, but as far as I think it does still have a clinical role, though, even though I don't use it much in my practice. Perfect example are athletes who, that they want to just get through that season and they've never tried it. And I think that given the circumstances, one injection might be safe to do and reasonable and still standard of care, right? Two is that they're just so painful, because I'm a big proponent of physio, particularly early on. If they're too painful, they can't even attempt to do physio. because they're in acute pain, you caught them at the time of the initial injury or symptoms, that might be a good indication to try that.
Okay, and so I think we're going to have to close it up there, guys. So I want to thank both of you for offering your time and your expertise to join us here in Ireland, and hopefully everybody who attended has learned a lot and got a better insight into both the non-surgical and the surgical aspects of non-arthritic hip pain. Thanks again.
Thank you, Patrick and Keelan. And David,
Thank you. Thank you for having me. I really appreciate it. It's great to see everybody.
That's great.